having the synthesis and conclusion of the session. So this is the structure we will be following, and we hope to follow to the time allocated and to get your attention. So this session is organized to give highlights about the evidence policy ecosystem in this country, its opportunities, challenges, and then with focus in the areas of clinical care, health system management and leadership, and emergency preparedness and management. So these are the three core areas or function areas of the health system. We will be focusing on the use of evidence and data. But since the topic is very broad, we might go to certain directions during the discussions, but we'll try to maintain that framework. So as I said, we have four distinguished speakers and panelists. The first is Dr. Alabal Bairu, right? Is that the way I pronounce it? Okay. So he is an economist and a lead researcher at the Policy Institute, or a Policy Study Institute here in Addis. He was a country economist and International Growth Center director by the London School of Economics and Oxford University, and he's a visiting research fellow at the University of California, Berkeley, USA. He has more than 17 years of postdoctoral experience in research and policy analysis, focusing on, among other things, on poverty, human development, labor market, food systems, nutrition, and health. He has published extensively. He is a member of the Ethiopian Economic Association, a global economic science association. He obtained his PhD in resource economics from Hohenheim University, Germany in 2008. Our other panelist is Dr. Malkamu. Welcome, Dr. Malkamu. He is a medical doctor. He had an extensive experience in health system leadership, and he has worked at various positions in the Amhara, and had been also a faculty at Wollo University. And notably, he had been the head of the Amhara Regional Health Bureau. He has worked and contributed extensively there. He has extensive educational background in clinical medicine as well as in public health. He has specialized in obstetrics and gynecology, but he also has masters in public health. From his CV, what I noted is he has special skill in managing the conflict in the north in 2, 3, 4 years back. He is currently the deputy director at EPHA, and he is managing the core functions there. So he has a very long list of experiences. Just for the sake of time, I have to shorten that like this. Other speaker panelist is Dr. Kasu. He is also a clinician, pediatrician with several years of experience in clinical medicine, medical education, and research. Currently, he is working at WHO as health system officer at the country office. In this capacity, he supports the use of evidence in health policy development and health system strengthening. He is also an adjunct position at Jimma University and at this Continental Institute of Public Health. He is also serving as the founding and current president of the University of Gondar Alumni Association. He has obtained his MD at Gondar and also MPH from Gondar University, and PhD in policy of health, politics of health policy, with a focus on evidence-informed and participatory health policy making from McMaster University, Canada. Our last but not least is also a distinguished medical professional, Professor Aklilu Azahe, right? Very difficult names. I'm encountering difficulties in pronouncing names. So he has graduated from Addis Ababa University, Faculty of Medicine, and has also done his specialty and subspecialty in emergency medicine, emergency and critical care. He has served as several leading positions, including medical intensive care unit, emergency medicines programs at Black Lion Hospital at Addis Ababa University, led academic programs as Associate Dean for undergraduate programs at Medical Faculty of Addis Ababa University and Director of Graduate Programs at College of Health Sciences. He is an advisor to the Ministry of Health in emergency and critical care and has several contributions in developing international and local guidelines. He is a founding member and the immediate ex-president of the Ethiopian Society of Emergency and Medicine Professionals and ex-board member of African Federation of Emergency Medicine. He has active engagement in research with more than 90 peer-reviewed publications in international journals. So you can consider these are very rich experiences, and you will have a lot of reflection during the discussions. So having this about the panelists, I will call upon Professor Aster to give us a quick overview of her current work as well as also trying to set the scene. Please welcome Professor Aster.
Thank you, Prof. Tsunel. ልቆም ልቀም እንዳንተው እንደጀመርከው ልቀጥ እንደምናደራችሁ EPHA ሁሌ ስመጣ እነኚህ ትላልቆቹን ያው the seasoned public health professionals ሁሌ ስናያቸው እና ዶክተር ተዋበች ዶክተር ተስፋይ አላችሁላችሁ አቶ ጥሩና ሁሌ ባለቤታቸውን ይዘው የሚመጡት እዛ ጋር ደግሞ ትናንት የነበረች በጣም ሲኒየር ነበረችና እንደው ሁሌ ፊት ብናስቀምጣቸው ሁላ አላለውና እናንተን እንዲሁም ተተኪዎቹን ደግሞ እንዲማየት በጣም ደስ ይላል። ቅብብሎሹ ይሄ ቤት እኛ ቦርድ ሆነን እንታገል ነበር ከኛ በፊትም የነበሩትና ተቀባብለን ይሄ ቤት እዚህ መድረሱ again congratulations to the Ethiopian Public Health Association and also እና እንኳን ለ37ኛው የኢፒኤችኤ አኑዋል ኮንፈረንስ አደረሰን ካልኩኝ በኋላ I have multiple hats. Professor Tsunel was introducing one of my hats, the lead executive officer for policy strategy and research. That is my newly hat, I would say. PSR, the policy strategy and research of the Ministry of Health, is a relatively younger lead executive office in the Ministry of Health. Maybe you have seen all our posters on that side and also here. You may ask why all these from the ministry, why the ministry established PSR. We all talk about evidence-informed policy making, evidence-informed decision making, evidence to policy. Who is generating evidence? My other hat, I am from academia. Maybe you know I am from Addis Ababa University. And temporarily moved to the ministry. We the academia, we all generate evidence. Evidence is generated by research institutes, partners, associations, but how much of our evidence are really being used to impact, be it clinical decision, outbreak responses, or impacting the policy in general. So, there was a big divide between us, I would say my other hat, the evidence generators, and the policymakers የምንላቸው ማለት ነው እና I think one of the main objective for establishing PSR is to bridge the gap between the generators and the utilizers, as I said. So we are serving as an engine for evidence-informed decision-making in Ethiopia. That's what we said. So, networking, linking between those generators and the utilizers. So as a result, we coordinate evidence to policy process in the country, strengthening knowledge translation. We serve as brokers. That's what we say. In my office, we are very few, but many. That's what we say. Very few, very young office, but very dynamic. And we also ensure all policy documents, strategies, guidelines, what you use in the clinical practice, everything is informed by evidence. And our office was also responsible. Maybe our health policy has been endorsed last year. So our office was responsible for the translation and dissemination of that policy document. That's why you see here. So you can scan, those of you who don't have the recent health policy document, you can scan it from here. And we also, as I said, ensure the networking between academia, research institutions, and the policymakers. That's what we are trying. You know the agencies, EPHA, AHRI are the agents of the ministry with their own mandate. We have started, working very closely, networking these institutions, but beyond EPHI and AHRI. So whatever we do in the past, how many, I think it's only 3 years old. It's now 10 months since I joined. So whatever we do, we started, as I said, we finalized and disseminated the health policy. And also one of our mandate is to set the health research agenda of this country. So we did that, a prioritization exercise, by engaging, at least to start, by what they call the research universities. So we are working with the 8 research universities, and also we engage the major professional associations, of course the Ethiopian Public Health Association, Medical Association, Nursing Association, Lab Association, and Pharmacy Association to start with. We also did some of our activities of, clearing the policy documents with Prof. Aklilu is here, the Ethiopian Emergency and Critical Care Society, right? So we are working our activities with societies, and also when we set the priority agenda, which is not yet a work on progress, we engaged the Animal Health Institute, the Environmental Protection Agency, and the Ethiopian Ministry of Education, because we know health is beyond the Ministry of Health, right? So we are trying, 1 minute. Okay, so we are engaging, we are using this One Health lens. So we are trying this collaboration, networking among the health research stakeholders. So for the interest of time, we are also trying to automate these all policy documents so that they can be reachable elsewhere, including the research management process, the health research management process. So maybe we will have more time other times. Thank you so much. Thank you for inviting us. With this, we have partners including keynote, WHO, JSI, and others. So thank you so much. Thank you, EPHA, for inviting us. Thank you, Prof. Samuel.
Okay, thank you very much, Professor Aster. So I would like to invite the panelists to come to the podium, please. So Dr. Allebel, Professor Aklilu, Dr. Kasu, Dr. Malkamu, would you please come to the podium? I don't see Dr. Kasu. Maybe he will join us later. Okay. Thank you very much. So as I indicated in the agenda, you'll be given a 3-minute speech, 3 minutes, the real 3 minutes. I'll be using a stopwatch here, so Dr. Allebel will start, and Professor Aklilu will follow, and the third person will be Dr. Malkam. Dr. Malkam will be the third speaker. So Dr. Allebel will be giving us a quick speech on the rationale for and benefits of evidence-informed decision-making across diverse sectors. Yes.
Good morning. I think let me first thank the EPHA to invite us here. I think I like the EPHA for, I think I have to thank for their IRB processing. They are so fast, and we are really, I appreciate that So I have to say that because I got IRB certificate with really right deadline. So let me now go to the issue. So I think, the experience on the evidence used for policy making is really vary from country to country, and also even within Ethiopia. That the use of this evidence is so. But generally, what we can say is that the use of evidence is something that related to a systematic use of reliable information. I want to underline reliable information for solving the development challenges of a public or a community. So policymakers are using this reliable information for solving, for making decisions like formulation policy or strategy or designing program. So sometimes they even use it to justify their policy, or just a problem requires some kind of policy to convince people or its citizens. So that's one aspect. But when there are a number of sources of evidence, so when I say reliable information, that depends on the source of the information. Like, for instance, they may use data like epidemiological data or statistical data like DHS or whatever, the administrative data like records from hospitals or etc., and make some analysis, and they use that one. The second major source of informed evidence is research, as you know. So rigorous analysis. Based on rigorous analysis, there will be there are some evidences that generated from research. So those evidence can be used by policymakers to make some decision. And sometimes, because of the policymakers usually are quick, and then they need some rapid response. So sometimes they use the experts' opinion, and that can be also used as an evidence for making information. And sometimes also they can use technical committee. They come from technical committee. So the technical committees also are some of the, I think, this big source of evidence for policymakers, decision makers to make decisions. Yeah. So that's finished. Okay. I will be coming.
Yes, you'll have more opportunity. Just to Professor Aklilu, can you give us a 3 minutes overview of the status and current practice of evidence-based clinical care in this country?
Thank you, Professor Tsunuel. Evidence is knowledge and power. In clinical care, this time, because of opportunities of universities, tertiary care, medical schools are expanding, the usage, awareness, and also generation of primary research data is expanding and growing. For instance, in hospitals now, adoption, development of guidelines, usage of quality improvement, quality audits, such things are very common when you compare these issues 20 years ago. Clinical departments and units are adopting and integrating evidence-based practice in their routine activities, like journal club, morning sessions, rounds, and so on. The journal club, which most of the time weekly or monthly undertaken, focus on appraisal of articles. But recently in many departments, in addition to appraisal, we are focusing on accessing, searching, synthesis, and usage, especially just contextualizing evidences. There is also just opportunity, because technology, digitization is growing, internet and smartphones are universally accessible. Therefore, our clinicians, consultants, residents, nurses, everybody most of the time go to up-to-date Google, PubMed and so on to refer for individual cases or when outbreaks just emerge. It reminds me epidemic dropsy, which Zait Mars, which emerged 10 years ago. It was a puzzle for us, but because we got a simple literature review from Indian subcontinent and we diagnosed that outbreak and solved the puzzle. Therefore, although there are gaps, there are also opportunity. Ministry of Health is now really a driving force because there are initiatives and policy frameworks on guidelines, quality improvement, continuing professional development, because these issues are also engine to move the clinical scenario and ecosystem.
You finished ahead of your time. So, Dr. Malkamu, give us also a quick overview of the role of data and evidence in public health emergency management. Thank you.
Data Daraj. Thank you so much, Professor Samuel and Professor Aster, for the nice introduction, and also EPHA for giving the chance to be part of this annual conference. So I'll give you an introduction on how the health system of the country is arranged. So now today we are discussing about this data. So there are two things. Those institutions who are generating evidence and institutions who are using this evidence. So the evidence utilization aspect mainly is at the Ministry of Health. And also today I wanted to make sure that you all are aware of EPHI not only generating evidence, it also utilizes evidence through its public health emergency management aspect. So this EPHI is one, we are generating data. The data in the country is coming through HMIS, the program data, and the other is the surveillance data. Usually people are not aware of this surveillance data. So this is a huge form of data that we have at EPHI. And the second point is EPHI is not only generating data, we are storing data of health-related activities. That is through our National Data Management Center. So we are not generating data, storing data, and changing this data to evidence. And the fourth aspect on this data is using this data for decision making. So that is through our public health emergency management wing. So this data is highly important for the public health emergency in terms of the preparedness aspect. The preparedness aspect is through risk profiling, is through risk calendar, through predicting and the modeling activities that we are working. And the other important thing is for the response. Unless we have the data, unless we get the information, we can't make it. So to follow this early detection, notification and response, there is a new introduction to the globe that is 717 framework. I hope that you all are aware of this framework. This is, we need to detect an outbreak within the first 7 days of occurrence. We have to notify within a day, and we need to be able to respond within 7 days of happening of this outbreak. So there is 717 framework, which is a global introduction. Now is highly acceptable and worked through WHO and different partners. So this is a global accepted framework. We are managing all the different outbreaks through this framework. So by using this framework, there are certain developments that we have seen, okay, in terms of detection, in terms of notification and the response aspects at the different pillars. And also, you know that this is the NAPS, the National Action Plan for Health Security, and the joint evaluation outcomes are now increasing because of the fact that we are using this data for proper decision making. All of these things are not without challenges, so we'll speak on the next aspects based on this. So these are in general the national arrangement, how the data is generated, how the data is changed to evidence, and then how we are utilizing the data. Thank you.
Okay, thank you very much. So is Dr. Kaso around? Okay, so that will give us some more minutes to add to the other speakers. Okay, so we will be continuing the discussion, and Professor Aster will be leading the first round of question and reflection.
Thank you, Prof. Samuel. Thank you, respected moderators. So, as you have heard, you have set the ground at one level from the Policy Study Institute. You have told us, the importance of evidence, the source of evidence, and most importantly, the evidence should be reliable so that it can impact policies and practices. And Prof. Aklilu has taken us through how evidence can be used in the development, adoption of clinical guidelines, quality improvements, the recent development in the use of evidence even in the clinical health setting. So, but that is not without challenge. And Dr. Malkamu has taken us how EPHA, not only as evidence generator, but as evidence analyzers. Maybe you all know, how many of you know, I don't know, about the National Data Management and Analytics Center at EPHA. So they not only store, but analyze it and use it to inform emergencies and outbreaks. So you have taken us through that, including the Global 717 framework, how evidence is useful to your institutions. So all of you have told us, of course it has grown up. Our culture of using evidence has been improving from years to years, but what you still said we're not yet fully using evidences, right? So what key factors do you think are contributing in using evidence at a large scale in your area of work? So maybe we can go in which direction? Dr. Prof. Samuel will decide. And what institutional, technical, cultural barriers do you think are most important in limiting the evidence uptake as much as we should? So shall I start from at one level and then we go this sequence? Okay, thank you.
I think there are a number of barriers for using this evidence in Ethiopia. The first thing, you see there are a lot of evidence that are generated in universities, research institutes, international organizations, etc. But one of the most, I think, important barriers, just research policy linkage is very weak in Ethiopia. So there is no, or there is very limited platforms where researchers can come and then give their evidences to policymakers. So the research and I have seen a lot of times where policymakers, through a lot of experience for more than 15 years in policymaking area, we invite people, scientists from universities, and they come to the policymakers. The way they explain the things is it's hard for policymakers to easily grasp, and that's one important thing that which contributes a lot, because they don't have appetite for that, because when they call the scientists to their office and then ask them for the way they explain for the policymakers is not in a way that those people are just policymakers are easily understand. That's also another key barriers in Ethiopia. The other one is even if you want to conduct research in Ethiopia, the data are very fragmented. Like for instance, you don't find data that links the food system with the nutrition and health. You may find some kind of data in the HS. You may find some kind of data through the agriculture sample survey. by the Ethiopian Statistical Service, or you may get some consumption data on household consumption data. But you want these data to be linked. You don't find that kind of credible. If you want to link those data, you don't find. You're not credible for that. So that's really one very important barriers. So the data we have is very fragmented. So there is no any integrated data in Ethiopia. So policy analysis requires connecting different variables into one data set, and so that you can see the patterns of the different policy variables, where they are going and how they pattern, the trend, and so on. So that kind of things are really also one important variables in Ethiopia. Finally, I think, there is also, I can say, limited appetite from the policymakers, from the Ethiopian policymakers, especially. I know the highest body, they need some evidence to make a decision, especially at the minister level or below that. There is low appetite for that. And add up this one with the weak linkage, with absence of platforms where you find the top leadership of the country where policy is made. So these are big barriers for the evidence-making policy in Ethiopia. That's it. Thank you.
Thank you, Ato Alebel. I would give the same question to Prof. Aklilu, but in the clinical setting. Thank you.
Thank you, Professor Esther. In the clinical landscape, there are multiple factors which are becoming barriers for uptake, adherence, and compliance. One important factor there is individual clinician factors which are related with knowledge and competence. When evidence-based documents or guidelines go down to institutions, perhaps clinicians may not be oriented and may not have the knowledge and the competence to apply. 7 years ago, we prepared emergency medicine guideline, and we distributed this guideline down to the grassroots level. But later on, we got feedback because professionals were not aware of oxygen management, mask application, flow management, so on and so on. Therefore, we were urged to prepare again a training document on oxygen administration and solve the issue. Therefore, competence and knowledge is really a very, very important issue. The important issue again is really the difference between guidelines and books. Many people do not know guidelines are really incorporating recent evidences which are contextualized. Therefore, people still believe on international evidence only. Therefore, this issue can be solved only by training and engaging people, also getting champions from institutes to explain this issue. Even senior people may not really accept new guidelines, believing the books or international evidence is better than the guidelines available. The other important issues are organizational matters. We experienced a lot on this issue during COVID-19 guideline, especially that guideline was, you remember, it was a living guideline because 3 guidelines were prepared within 2 years' time because evidence was emerging and growing. In the first guideline, clinicians were not engaged on the development of the guideline, and because of this there was resistance, and we solved this issue on the second guideline involving clinicians from all over the world applying technology, Zoom meeting, and so on. Similarly, we identified important barrier was setting at that time. Because isolation was strictly recommended and the usage of equipment in isolation for different patients, but setup was not really adequate. Institutions were crowded. Therefore, whenever we encourage people to use guidelines, we have to address the setting issue, which is related with equipment, drugs, supplies, including the knowledge which we mentioned. In the setting, leadership is also a very important issue. In institutions, unless leaders have a buy-in or accept it, they will not sponsor or they will not adjust all issues I mentioned. In the COVID-19 guideline time, leaders were really very good because that was a pandemic issue. The nation, the whole apparatus of leaders were moving. There was no problem on the leadership acceptance of guideline. But the setting and the users was a problem. The other important issue, again, is the guideline itself. As I said, if guideline is not engaging people from the very inception level and orientation is given at different steps, implementation, uptake, and adherence will be really very, very hampered or affected. Again, the guideline document itself should be appealing. Many times, guideline development, our developers are not trained on scope of guidelines and appearance and the rigor of evidences. Now, the evidence content could be poor and it may not be appealing to users. The flow may not be really good. Even editorial issues may not be good and people may not accept the guideline or evidence. Therefore, the guideline really should be appealing and the appearance, everything should be good. Now, in the Ministry of Health, because there is a governance system in the policy, strategy, and research, now there is a quality assurance steps because there is standard and standardization of guideline and evidence material development. Hopefully, this structure of the guideline component issue will be solved in the future because clinicians are not even aware what adaptation is, what adoption is, what really de novo development of guidelines and so on. Therefore, this is really opportunity for us to build capacity of clinicians so that clinicians will be engaging on synthesis of evidence, contextualization of evidence, and use of evidence so that there will not be barriers in the ground level.
Thank you, Prof. Aklilu. So I would forward the same question to Dr. Malkamu, but before that, I have to get corrected. My co-moderator has told me, I repeatedly say Mr. Al-Level, but he's Dr. Al-Level. So, Lemon, thank you.
Thank you so much. Most of the issues are raised. I think this is a very nice platform to talk about those things. So, I will talk about three practical issues. So, one is the use culture. Okay. The barrier is the use culture at every aspect. Every researcher wanted to influence the Ministry of Health. Okay. Every researcher to have an influence on EPHA. But the use has to start from the ground. Okay. We need to work with the waradas, we need to work with the zones, we need to work with the regions. Okay. While I was working as a regional health bureau head, everyone is thinking about having these publications and changing the policy at the national level. But we are not closely working with the regions, with the zones, with the districts down there on the community. So, while thinking the data that we have, the information that we have, we are also thinking only those who are published to these peer-reviewed journals. there are different data, there are different information that we can use for response. So the first thing is we need to improve the culture from both sides to use the data at different levels. Okay. If you are thinking that there is, if the modeling shows that in one of the districts there will be landslide, okay, that has to be used to that area. So we need to make this influence, the data use aspect. We need to start from the district level to that of the national level. And the reverse way also works in that aspect. I clearly know that. And the other thing which I see usually, when we generate data, for instance, one of the universities, they will never ask the regions, they will never ask the zones, what are your priorities? What are your points to be included in the research for the data generation? And even while teaching our students, we need to use the local expertise. While, for instance, in speaking about this, in teaching health economics about the community-based health insurance and other aspects, the one who is leading the zones, the districts down there, knows the practical aspect of what does this community-based health insurance means. So we need to work closely at different levels, not only at the national level. The national level is critically important, but we need to work at different levels, data generation and data use aspect. One is that. And the other is, there are so many data, there are so many evidences, but that is not changer to information. This is the critical one, and the communication aspect is also included here. There is a point that the researchers are saying that there is a low appetite from the policymaker side that they don't want to use our evidence. And the policy side, we are saying that the evidences generated are not from our priorities. So that's why Professor Astier's office is established. So that is to bridge this gap. So there are so many data, there are so many evidences, but that has to be changed to information and communicated to the policymakers. We have so many data, but there is no information. The policymakers don't have time to read all these publications, to see the long listed pointers. So it is good that to change the communication aspect. We need to have a short, summarized information which will really influence the policymakers. So we have to make the data to information. So, and also we need to communicate in the way that the policymakers are listening. So now there is a growing appetite, there is a growing thing. That's why at the ministry level there is a policy, the executive office, and also data management and analytics center at EPHA, and there is a growing interest in this aspect. This is manifested practically. And the last point that I wanted to mention here is the use aspect is not yet institutionalized. I'm saying the data use aspect is not yet institutionalized. The storage, the analytics is institutionalized, but on the use aspect is not still institutionalized, and it needs further work to change the culture, to work at the institution level, be it at the facilities, as Professor Aklilu was mentioning, and at different levels. It has to be institutionalized, and it should be culture. For this, we need to push on the advocacy aspect, on the communication aspect, in coming and working together, in changing the data, the evidences that we have to information. So this will make a great improvement, so that we can get what we want. Thank you.
Okay, thank you very much, all the panelists. You really raised important points. I would like to add, I used to be a clinician. I said I used to be because I stopped clinical practice the last 10 years. Otherwise, I've been wearing gowns and, going to the hospital. So there is, even guidelines have got their own inherent limitations, unless they are frequently updated, unless they are based on available best evidences, unless they are pragmatic, they could be bottlenecks. We've done a couple of research assessing whether physicians or clinical providers are sticking to guidelines. The finding is striking. They follow only in 30% of the cases. And the worst to follow guidelines are medical doctors. And there could be several reasons, but one of the reasons are guidelines are rigid. They don't give flexibility for individual variability in patient care. They talk about the average person, not the individual specific person. But when you evaluate a person, the one person is very unique in terms of clinical features, treatment response, and so on. So they should be really further discussed on how do we develop clinical guidelines and make them more flexible and robust. AI is now becoming one potential for users, just to add to this reflection. So we'll go to the second round of questions or reflections. So you've told us about the challenge, the gaps, and the problems with the use of evidence in decision-making or practice. Now let's turn our face to opportunities and best practices. So can you give us one best practice to highlight the existing opportunities and how we can leverage those opportunities to really improve the use of evidence and decision-making in your area of work? I know, Dr. Allabal, you're covering a lot of sectors, so you can give us an integrated approach. And Professor Akrilu, you can contextualize to the clinical practice, and Dr. Malkamu to the emergency response. Mind you, this is for practicality, otherwise we are not saying they know only about these fields. I know you have broader knowledge. Over to you, Dr. Allabal.
So you want me to say some good practices? Yeah. Okay. Oh. Okay. Let me start with the. We have a lot of good practice at PSI. Over the last maybe 16, 17 years, we had a lot of communication with the policymakers. So when I say policymakers, I'm just referring to the Prime Minister office and at least the ministerial level. I think, let me tell you what you know. Let me start with the Ethiopian Community Exchange, the ECX. That's one important influence that we did during the late Prime Minister Meles Zenawi. And also the formulation of growth and transformation plan, the first two growth and transformation plan, and now currently we had a lot of background studies for the formulation of the 10 years perspective plan, which is currently going on the other most important examples that I can tell you is like the agricultural growth program, which is a multi-million-dollar started in 2011 in Ethiopia. So the first phase of that program had not a component on nutrition. So we were told to evaluate the first phase in 2015-16. So we came up with the proposal that this program should include a nutrition component because it had only a productivity component and also a commercialization component. The program was implemented in high potential area of Ethiopia, over 185 or some 65 districts. So if a nutrition component is included here, so I think that would be really the easy way, means strategy to reach many people in Ethiopia. So in the second phase, they included that component. That's one important aspect. So we were closely working with, currently what we do at PSI is we have a policy dialogue platform at PSI. What we do is, like if one researcher has some idea on a particular area, like maybe on nutrition or education or whatever, he has to or she has to go to the minister and discuss with the ministry if that idea is good enough for them, and they can collaborate to work with us. So if get approval from that, they will do it. And along the line, we engage those people from the ministry to work with us. It's a kind of implementation research that we do now currently. So we have a periodic platform where stakeholder policymakers from the ministries and researchers at PSI came together and discuss issues. And also after a preliminary finding, that has to be validated by the stakeholders, by the ministries. And then finally, we provide that. The other good practices, we usually work in the formulation of policy. You see, when a minister, like the Minister of Agriculture or Ministry of Education or the Ministry of Environment, if they want to develop a policy, they work with us, and then members of the PSI researchers will be member of the technical committee of the preparation of that one. So the other, I think, let me generalize, conclude this one. When do we say evidence is taken by the policymakers? First, you want the policymakers to think strategically first. Whether that is taken to the policy making process or not is another thing. So policymakers, they need some ideas how to strategically address a particular problem. So when you create a platform for them to discuss those issues, they are able to strategically think that problems. That's one aspect. That's a big contribution, by the way. Second, the second important, policymakers may want to develop a policy. So they want evidence in that case. Or they want you to involve in the formation of that policy. So the second important point, entry point for evidence generation usually is just in terms of formulation of policies. The third one is where policies are implemented. You know, when policies are implemented, they need to be evaluated periodically. Or maybe programs, they need to be evaluated periodically. So in that case, you should have some kind of platform where these programs should be evaluated. Like, for instance, currently what we are evaluating the 10 years perspective plan, because now it's 5 years. Okay, so we are evaluating that one. That was the discussion that we had with the Minister of Planning. So from this, what I can conclude, just creating a platform where policymakers and researchers are usually have some kind of platform to discuss is very, very important. That's what I can say. Thank you.
Thank you. We would like also to hear not at least one best practice for the sake of time. I know you can cite a lot of best practices, but one best practice from your area of work that shows how we can change evidence into policy.
Professor Tenuel, I said earlier, evidence is power and evidence is knowledge. Julius Caesar also said, knowledge brings confidence and confidence brings victory. Ethiopia's example of the spring which was controlled and contributed to victory of Adwa is really immortal history. Therefore, even smaller evidences are really important and life-saving. Now I'm going to tell you one example from several ones in emergency medicine development, because emergency medicine development came in a very difficult scenario where there is no setting. The setting is precarious or really non-existent. But currently we have professionals working over 120 hospitals in Ethiopia where emergency and critical care physicians are working, and there were 5 ICUs in Addis Ababa 10 years ago. Now we are working in 150 or more ICUs. But there are really very interesting stories. Maybe I'll tell you one just story where small evidence, in fact that is a point prevalence study, just a day study which changed a landscape. In emergency department we say September 14, 2014 incident, because it is a one-day summary, but it changed a landscape. That was a Sunday afternoon, and when I go to emergency department, it was very crowded and in hell state. Therefore, I started the round and we documented what the cases are, where they came, what procedures were done, and so on. We found there were 40 patients in the emergency floor, and then among them 24 were trauma cases, that is 60%. Among them 14 were neurosurgical patients, that is 25%. There were orthopedic cases and so on. Yes, it is sad. In fact, there were patients who had major procedures like burhole, elevation of depressed skull fracture and so on, which are supposed to be admitted to intensive care unit, but they were kept in emergency department. Therefore, I summarized this data, just an afternoon data, and then I shared this data to Ministry of Health directors, including the minister at that time. Really, I really appreciate how our ministries are sensing and responding when we take even small just evidences. The next day, the minister sent a committee because it was really alarming how that department was crowded and how difficult cases, including intubated cases, are there with a very long stay in the emergency room. Then that was really the beginning of trauma center establishment in Ethiopia. Then because of that discussion, within 4 months' time, we opened Alert Hospital Trauma Center. And then the ministers really were committed to strengthen ABET, Black Lion Hospital, and also include trauma care in the guideline and develop private facilities in trauma care. We see that there is a change, including very critical care, although we have a challenge in pre-facility care. Therefore, our department now, there is a motto in our department wall that says, our patients cannot go to the minister because they have a broken legs. And our patients cannot speak with the minister because they are comatose. Therefore, let us work and let us go to the policymakers, let us speak for our patients, and let us collect best evidence to convince them and to persuade them. Therefore, the message is really little evidence even can change life. I told you in epidemic dropsy, that was a very difficult scenario in Addis Ababa. It was not really systematic review or other big evidences, just which help us to diagnose that problem. It was a literature review. Therefore, opening an eyes and look for evidence, and then taking to policymakers and include or insert in the genomics of policy is really very important. Therefore, for us, for clinicians, just to be seated and working for individual patients is not really cost effective. We have to really see for evidences and take these evidences just with a small review or just policy review level. Thank you.
Thank you very much, Professor Aklilu. This is a very, very fascinating story. And that should be written. I don't know if you have published this. You have published this. Excellent. Over to you, Doctor.
Thank you so much. Thank you so much, Professor Aklilu. He mentioned that how communication really worked out. This is not the level of evidence. This is the level of how we communicate it. This is what I was talking about, changing our data to information and communicating to policymakers. I really appreciate that. So from my side, I will raise 2 points only. I can mention many, but there are 2 points. One is, you remember that there is resurgence of malaria. There was an increment in malaria like 2 years back. Now this malaria is going down to, it is virgin when it has been in like 4 or 5 years back. When there is an increment of that malaria, our forecasting team said that by next year, this malaria will increase by 13%, 13%. And we made our preparation with a margin of more than that. But when it appears, the malaria was increasing all over the country. This is a global problem. That was an African problem, and that malaria was increased. So based on that forecasting evidence, we were making all the necessary preparations. We were making all the necessary preparations, the preparedness aspect. All the supplies were down there on the ground, and when that malaria was increasing, okay, we're given all the collective efforts that we have, starting from the ministry. Everyone was down there. We campaigned. We have made the proper preparations. So we responded in a better way. So one thing I want to say is our forecasting really worked out. And the second point I want to mention is this. You all know that there was a measles outbreak. A measles outbreak in the country with about 400 waradas were affected. So for this, the ministry had a national level catch-up campaign all over the country. What we did for this was, we were analyzing the last 15 years data. Where are the epidemic prone areas? Where are the areas frequently affected by this measles? So by doing that, we were able to identify more than 18 waradas, 18 waradas. So we made our joint efforts with EPHA and EPI team, and we are managing these districts in a targeted way, and specifically down to the districts. So by that, we are able to control the measles outbreaks. Now the measles is down. So these are the most important and the critical areas where we use this data for this evidence for intervention. This is a practical one. I can mention more like Mpox and Marburg. As for the time purpose, I will stop here, and I may speak on that if there are raised on the question and answers.
Perfect. I know had it not been for time, we could have heard a lot of interesting stories. So, as we promised, this is time for the audience to question or give some reflections to the panelists. So we have 15 minutes for this session. And first, let me see the number of hands, and I will decide. Anyone interested, please raise your hands and let's see. Okay, we have 1, 2, 3, 4, 5, 6, 7. So, how much should I give? Okay, so we'll give all, but just one question per person. Please make it short and just one, please. Okay, I will give 1, 2, this is your number. 1, 2, 3, 4, 5, 6, and 7.
Thank you. I would like to congratulate all the panelists and moderators. It was a very exciting experience to listen to what was going on and what needs to be done. My question, it's not actually a question, but when we talk about policy, I want some clarification. Should policy always reflect the top, or is policy. It's a chain that goes from the top to the bottom. So leaving one point in favor of the other would not give us the full outcomes that we are expecting. I would like to also emphasize on the need for information, awareness raising, public participation, and knowledge sharing at various levels. So where do the professionals fall in this policy chain? Because sometimes a researcher does his or her research, and then the policy brief goes to the highest level, while the practitioners in the middle, the actual users at the community level, are not fully and clearly targeted. So what needs to be done to improve this situation, or are you okay with what's happening?
Thank you. Thank you. So, one question per person.
Thank you, Mr. Chairman. Thank you, panelists. We used to say Ministry of Health is good in developing strategy documents, guidelines, and so on, but there is a lack in disseminating and orienting the users, particularly at lower level, as already mentioned. So I'm happy to hear from Professor Aster that this problem is going to be tackled with the help of your office. Other comment I have is with regard to use of data for decision making. It's to improve the quality of particularly the data could be garbage in, garbage out. So one has to be careful in ensuring the quality of data. Quality of data can be improved if data is used by the level at which it is generated, particularly. As my friend you mentioned, it should be analyzed and turned into information, basically, and used immediately, timely. This is very important. So this would require capacity building at particularly the level of health centers, lower down, who are actually providing information based on what they observe and what they actually have to do throughout their practices. Thank you.
Third person.
Thank you very much. My name is Onet from St. Paul's Hospital. My single question goes to Dr. Mercamo, probably. We have a lot of data generated through academic institutes all over the country. What is the challenge of getting all the data to generate evidence from the EPHA's point of view? Thank you.
Thank you all, and I think I would like to appreciate the point prevalence data and how it changed actually the policy and practice. So my question is, generating evidence is one thing, but the communication is most important. Communication to policymakers, but also to researchers and also practitioners. How is that being handled in all cases, especially in Ministry of Health as well as EPHA and the PSD? Thank you.
Thank you. My name is Minilik. My question is regarding to the MPOX. When it was raised in South Omo, there were some contradictory aspects towards this disease. Why it was happened? Because the first physician were maybe affected, or he may disseminate without any ethical aspects. So, is the management, this health information management system or surveillance system have an ethics? Were they included in the guideline or not? Please verify this. Thank you.
Thank you so much. This is Damto. Thank you so much for the enlightening panel this morning. The first question I wanted to pose is related to rigor of or strength of the evidence. In a country where randomized controlled trials or cluster community trials is not as high as, for instance, neighboring Kenya, how do you comment on the existing quality of evidence? The second point, some 84% of the Ethiopian population do live in the countryside and primarily benefit from primary health care settings. How do you ensure correct and consistent use of the existing evidence at the lower level? And finally, the engagement of community or public in the development of this evidence. Primarily to Professor Akrilu, I believe one of the best clinical care is patient-centered care. How are patients engaged in formulation of these evidences from planning stage up to prognosis or whatever the last stage may be? Thank you.
Thank you for the opportunity. I think this is a very critical issue, and what now as a gesture from the ministry side is really encouraging. We have to congratulate ourselves because establishment of data translation unit as an interface between researchers and policymakers is a stance that we had never had before. The problem we had is we don't define our agenda to start with, national agenda for research, and all research institutions and universities do not derive their agenda from that. That's where the problem starts. Secondly, there is this dichotomy between research people and data policy people. There is a publish more and read less dichotomy because researchers want to publish more. They want to publish their work in different journals. Maybe they end up in salami pieces, not scattered information, but policymakers want packed information, synthesized. You know, it's not sufficient to translate data into information, but we need to make it knowledge. Knowledge is more than information. Knowledge is information plus criteria or practice or experience. So I think we need to have a common agenda, research agenda to start with. Secondly, we need to communicate with implementing sectors in a distilled way. So we have to take this assignment. Research group should change their research output into policy briefs, issue briefs, and simplified policy languages so that it is user-friendly for the end users. And thank you very much for.
Okay, thank you very much. I think the majority of the points are compliments and additions. I would like to forward this saying, you know, in the chain of knowledge management, there is a saying, not all data is information and not all information is knowledge, and not all knowledge is understanding, and not all understanding is wisdom. So this is a hierarchy. So I think we need to keep that in mind. So I think I would like to sort of aggregate the questions. So one focuses on the quality and rigor of evidence, including RCTs. The other is on access to data and communication using a proper channel. The third is involvement of community and other stakeholders in evidence generation, design of policies. Okay. Maybe you can reflect on these three aspects. Each of you, I'll give you 2 minutes. And there are also specific questions that were forwarded to Professor Aklilu and Dr. Malcolm. So we can go this way.
most of the questions are there, but I can. Okay. Yeah.
Thank you. I have some specific questions, especially starting from Prof. Danda's question. Engagement of patients in patient-centered care is very, very crucial issue. That happens in several levels, but the most important issue is explanation of treatment or care we are giving to patients. That is important just in every routine day. There are not really strong research in this aspect, but from our observation, there is really huge gap. That is really very important area in the future, which we should improve from nurses' side, physicians' side, all aspects. But the second point also is engagement of users, including patients, in guideline development. That is very important. Patients should be engaged in many of chronic care guideline development, again from inception level, because patient perspective context is very, very important, because guideline and evidence usage after all is contextualization in addition to the best available research. Therefore, this should be a way forward. In developed countries that is being done, but in our country that is a way forward in chronic care like diabetes, hypertension, asthma, and so on. Maybe it may be difficult to do this in all guideline like emergency, where you may not get really real cases, because in emergency mostly patients go to just other chronic care program. And the second is the rigor or quality of evidence. I think now in our country also systematic review is being done in low and middle income countries, some in Ethiopia as well. Therefore, as long as lots of research are being done, growing, the future is really bright, because we will have just our own data and synthesized data. But we can get this synthesized data from other countries, developing nations. But the most important thing is, again, contextualization. That is also our comment also in journal club discussions in the morning. Mostly clinicians are interested in the quality of data only, but the issue is external validity. Do you really apply to your population, coming to the context, patient value, and different things? But that does not mean that decision is only based just on the best, the quality evidence only. But the point is the best and also available evidence. Therefore, it is like a hungry person. A hungry person just don't need a cake, but hungry person just can take just any good food for that matter. Therefore, just any level of evidence which is best for us is really important. That can be from longitudinal study, sometimes even just a single case scenario, or as I mentioned, a literature review that can help depending on the scenario. There was also just a similar communication issue which is raised based on our point prevalence study by Dr. Fikram. I think the communication is really vital. First generation of just evidence is important, but communication is the second important issue. For communication, important barrier is we don't have really initial collaboration, friendship, acquaintances, and so on between institutions. That is really very, very important. In my case, because I am working with the Ministry of Health in advisorship, because we started emergency medicine program that was not existing in emergency in Ministry of Health itself at that time. Therefore, we already built the friendship, the connections, and collaboration. Therefore, that is really one important issue. Therefore, the media of communication, the content, all these issues are important to transfer our information to the decision makers, because ultimately the decision makers are importantly deciding on these issues. Thank you.
Thank you so much. I'll be very brief. So some of the points are just comments, and we'll take it as a compliment, so that the main intention was to knock your door, okay? To knock you. These are the interests from the policymakers. These are the interests from EPHA, from the Ministry of Health. There is advancement, as you acknowledged. So we have launched this FEM Center of Excellence last May 2025 in the presence of Her Excellency our Minister, Dr. Magdas. And we were evaluating this, our journey on the past 1 year, specifically on the digitization aspect in the different documents that we have. So we are now making the foundations for data to come to EPHI. So this DHIS2, all the health center, all the health facilities, and also the districts are responding through that, and we are planning to make one hub at EPHI. So there are different pillars under this Center of Excellence. We are planning to have for Africa and for the globe. We are in a position to be a collaborating center for WHO. That application is on progress, and we are going to make it with the sooner possible. So this will be a platform for others to come to learn, you to come to do researches. That will be a platform for all of us. So one is to announce this platform. You can come and you can use. So this is open for all of us. So one of the pillars for the Center of Excellence is evidence generation and data-driven decision making. So this is one thing that we are working on, and we have the data at National Data Management Center. So the main intention of having data management center is to analyze it for forecasting, for decision making. And the second point is to make this data accessible for all of you, to make a research, okay, to use it for any kind of activities that you want based on the data sharing agreement. So the foundation is made. We are institutionalizing it. You can come in and you can see that is the point. At the corner of it is the community. The community is at the center. As you all know, every emergency started and in this at the community. And also people are saying resilience at the same time is started and in this at the community. So we are investing at the community with the initiative of this Community Public Health Emergency Management. That is the entire one. And evidence generation and using is one part. So the primary health care aspect is also a part of it. So we are investing and we are strategizing in that line. And also the data quality usage at different levels is one of the things we need to work on. So the most important thing is the communication, as it has been said. So the different, the higher educationists and the researchers at different levels, they can come and work with us. So the ministry is in a position to give such priorities and translate it for using data. It arranged as executive office. Professor Aster will add on some of the things at the finalization. But we are now making the foundations for the data to use. Thank you so much for mentioning that using data, where the data is generated, is one important thing to give the data a quality one. And also we are using this data to make it to be a quality one, using this data at different levels. And also we are now in a position to integrate this AI as well, in terms of chatbot or in different ways for data quality, for teaching, for learning down to the community with health extension and others. We have different ambitions. I think as to Mpox, I think that question is for Marburg. That is not Mpox, which is happening in Jinka. That is the Marburg one. So this was identified at the health facilities. There is one initiative which is called FEM at health facility, Public Health Emergency Management at health facility. There are different areas where we identified that outbreaks are coming. One is at the border from different countries. The other is at the community. And the third is because most of the people, when they feel sick, they are coming to the health facilities. Okay, at the health facilities. And the fourth point is at the fragile settings, like IDPs. and refugees, returnees. So these are the points where we have identified to be an amplification in the source area for outbreaks. So there were trained people, trained health professionals by this FEMA Health Facility Initiative. So when they saw this cluster of cases with bleeding, with the same symptom, with the same family, they were in suspicion that this could be an outbreak. This could be hemorrhagic fever. So by that we made the necessary investigation and we were able to detect it earlier. By the way, if you see other different countries, you can mention Rwanda. They have identified when it hits Kigali, but we were able to identify at Jinka. That's a different story. So by FEMA Health Facility, we are advocating our health professionals to use the proper guidelines. We are managing any kind of patients, irrespective of the symptom. But the using of this, adhering to the guidelines, depends on the individual perspective, as it has been mentioned by Professor Akli. So we are advocating and to make all health facilities in the country, not only as a focal, but also entirely the health facility should be ready to detect and to respond any kinds of outbreaks which will happen in the country. That is the plan and the initiative we are using. So we are working in a holistic way. The communities at the center, RCC, that is communication and community engagement, will be at the pillar. We are working in that, and I can mention and I can confirm for you, we all are ready to collaborate. Thank you.
Thank you very much. So I will hand over to the next session. You have something to add?
Yeah,
okay,
yeah.
Let's make it quick.
I think the point, Lady Enders, just one information, at least for policies and strategies that need to be ratified by the Council of Ministers or the Parliament, there is a guideline at Prime Minister's office. That guideline, I don't know if you have it, at least there are some checklists. One of the checklists are just if the communities, particularly the policies that is affected by the communities that's affected by the policy, whether the voice of those committees are included on the policy document before it comes for approval, should be included in the draft policy document. So the Council of Ministers, when they discuss on the policies, the draft policies, the first question they ask is, where is the voice or the comments or the feedback from the communities? That's one. And the second one is when you identify if that problem really requires policy, you need to have justification for that. That justification should come from evidence-based. And that's reliable evidence. That's one point. The second point, which is a very important point raised by RCT. Yes, I know. The Kenyans and other countries are conducting RCT. As you know, RCT should not be the only methodologies that we can generate evidence. One. Second, as you know, RCT is very expensive. Especially, you don't really get as rapid as evidence from the decision. So, for that matter, so every evidence should not be, so that's what, there are a number of methodologies that can generate reliable and credible evidence. That's, thank you.
Okay, thank you all the panelists. Thank you all the panelists. Now we summarize. Dr. Al-Label has informed us how his institute used policies in the development and transformation plans, ESEX, and the different platforms that you use to bring all key players to avoid fragmented evidences and bring the other sector ministries for a common goal. So with the challenge, I will come to later. Professor Aklilu has told us how a single evidence was used to the extent of establishing a trauma center among the very many experiences that he has. And Dr. Malkamu has coming from the institution where they are both generators as well as evidence utilizers, has informed us how forecasts helps them. Just he was giving us measles and malaria as an example, but the recent Marburg, COVID, how evidences were used for the response and preparation of outbreaks. And with the barriers, all of them have told us the cultural barriers, culture of collaboration, culture of working together, culture of engaging the community, the divide between the academia and the policymakers. They are telling us we are only publishing with the publish or perish principle, but nowadays there is a growing appetite by the policymakers to use more evidence, and also the competency barrier. The competency is not only on the evidence generator side to communicate to the other side, also in uptaking evidences. So they have given us examples of their institutions, but to summarize, evidences has to be reliable. Garbage in, garbage out. So the quality from the grassroots, those who enter the data, those who collect the data, the patients, the community, who is telling us their problems. So it has to be all the way from top down, from the grassroots level up to the higher level. So evidence has to be reliable and it has to be of high quality. The next one is co-creation. መጨረሻ ላይ መተን እንኩ ኤቪደንሳችን አይሰራም. So we have to engage from identifying the problem level, identifying the problem, inception of the study, until the end of utilization of the data generated. So the collaboration has to be health centerንም ከታች ጀምረን እስከ ላይ ማለት ነው, engaging all the respective health bureaus. Universities are across the various regions, so we have to really work with the districts, the regional, all the health bureaus when it comes to health data. But I have said health is beyond the health ministry. Climate scenario, it's another ministry. The other one regarding the governance, again, if there is improvement, we need more knowledge translation unit in the research institutes, in the universities, is trying to do, enhancing the capacity of knowledge translation in that country. The last one, I will come to communication, collaboration, ብለናል. The language that we speak to the community is completely different to the policymakers, and also when we publish papers. So we have to be able to speak different language. አማርኛ እንግሊዝኛ አይደለም. አንዲት ደቂቃ አንድ ምሳሌ ብናገር ፕራክቲካል የላብ ባለሙያው ማይክሮስኮፕ እያየ ፔሸንቱ ስቱል ያው ታውቃላችሁ ሙልት አድርገው ነው የሚያመጡትና ስቱል ካፓ ክፍት ናት፣ ስቱሉ ሙሉ ነው። የላብ ባለሙያው እያየ ነው። ያው ዶክተር ነው የሚሉት የት ላድርገው አለው። አስቀምጥና ንካው አለው። ወጣቶች ንካው ታውቃላችሁ አይደለ? ንካው ሚንስ ሂድ ነው። በት ለዛ ገበሬ ንካው ማለት እንዲንክት ማድረግ ነው። So we have to speak the language of the policymakers, the journals, the community. እንደዛ ማድረግ አለብን, and we have to be able to know the elevator speech አይደለ? I think with this I will complete my summary, but I will give the chance to the three of them any call of action or a single takeaway message.
በዚህ በአጭር ጊዜም እንትን ለማለት ባለን ሪሶርስ ሶልቭ ለማድረግ ኤቪደንስ መጠቀም ምንም የመጠቀም አለብን ብዬ ነው የማስበው። አለበዚያ ኤክስቴንድድ ይሆናል። ስለዚህ ለዚህኛዋ ደግሞ